historically, colorectal cancer treatment has essentially led us from a 6-month overall survival to close to 33 to 36-month overall survival over the last decade and a half. A lot of it has to do with the availability of a large armamentarium of cytotoxic agents, irinotecan, oxaliplatin, 5-FU, then add capecitabine, and then TAS-102 is another cytotoxic agent, an explosion of biologic agents, 3 VEGF inhibitors, bevacizumab, ramucirumab, zivaflibercept, 2 EGFR inhibitors, panitumumab, cetuximab, and then a multi-kinase inhibitors that targets VEGF plus other targets, and that's regorafenib. A lot of agents available to us. Most patients will go through 2 lines of therapy. In fact, most patients today go through 3 or 4 lines of therapy, and even many patients can get up to 7 lines of therapy. So beyond 3rd line, so patients, let's say a KRAS or RAS wild-type patient would receive bevacizumab plus chemo 1st line, EGFR inhibitor plus chemo 2nd line, and then the 3rd line would be either regorafenib or TAS-102 for the KRAS mutated tumors, or the RAS mutated tumors, I should say. So it's usually chemotherapy plus bevacizumab. 2nd line is usually the other chemotherapy plus minus bevacizumab. And then the 3rd line would again be regorafenib or TAS-102. So at this point of time, when we look at the 3rd line space, there are 3rd and beyond, there are 2 agents, TAS-102 and regorafenib. Both were looked at versus placebo. Both were looked at in patients that were refractory. The 2 have never been compared head-to-head. The TAS-102 study included about 17 to 20% of patients who had prior regorafenib. The regorafenib study, because it came before the approval of TAS-102, does not have any TAS-102 prior to regorafenib.